Hello, I'm Emir Benbow. I am President of Manchester Medical Society, and welcome to Society's Christmas lecture for people. The presentation will start in a few moments. It's called the Wedgwood Lecture because Dorothy Wedgwood was a medical student in Manchester about 110 years ago, and then became part of the Wedgwood family, who were wealthy because they made pottery. Today's speaker is Professor Andy Ustinovsky, and I'm going to tell you about him in a moment. Andy is a professor in the University of Manchester. He works as an infectious diseases doctor in North Manchester General Hospital, where the regional infectious diseases unit is, but he's become very, very important to our response to COVID. He's been involved in studies. He's been involved in deciding which studies ought to be prioritized. He's the joint and national lead for infection for the National Institute of Health Research, and that's an extremely important body in deciding what research we do. And he's the national clinical lead for our vaccine research program. So again, he does some seriously important things in terms of prioritizing what happens next. So Andy's going to speak on the how and why of what we do about COVID. Andy, over to you.
Great. Well, thank you so much, Amir, and thank you for the invite and the possibility of talking to you all. And I'm delighted to talk about almost anything related to COVID, actually. So the topics that I'm actually going to cover are mostly COVID generally, and then concentrate on the vaccines, because that's really where I spent a lot of my time in the last 18 months or so, and where a lot of, I think, our current advances and future advances rest. So overall, I'll start off talking about what is SARS-CoV-2 or coronavirus 2, and what's COVID-19, and what's the difference between the two of them. I'll then touch on our initial response when we first knew there was a pandemic coming. What kind of therapies did we have? How do we decide what to treat with? Social measures, masking, social distancing, lockdown, etc. I'll touch on. And then on vaccines. How do vaccines work and what are they supposed to do? What types of vaccines have we got? Briefly, what kind of results have we obtained in COVID? How to communicate these results and more generally. And then very topically, I'm going to touch on variants and the future. So let's start off with what is SARS-CoV-2? Well, you can see a graphic here of the virus. This is obviously very, very small normally, only seen with an electron microscope. And it gets its name coronavirus because of the spikes that you can see, the bluish things sticking out from the viral surface. These are thought to look a little bit like a crown, which is what corona is in Latin. But it's not the only bit. Within that shell of spike, there is a membrane, there's some envelope protein, and within all of this, you've got the RNA, the ribonucleic acid, that is really the important bit of the virus. I will come back, however, to the spike protein because it's really key for our immune response and for how vaccines, etc., work. So what's COVID-19? Well, SARS-CoV-2 is the virus. COVID-19 is the disease. So COVID-19 is what we develop when we're exposed to SARS-CoV-2. The most important part of your body in terms of being affected by the SARS-CoV-2 virus are your lungs. And here's some chest x-rays of an individual over time where you can see that their lungs progress to getting very cloudy. And this is the inflammation that's developed in their lungs as a result of COVID-19. This particular individual, if your screen's a little bit better than mine, you might be able to see at the top right of the x-rays, which is the top left of your chest, a little darker bit or lighter bit, which is where the pacemaker is. And that's relevant for this individual because people with certain diseases, including heart diseases, are more prone to severe infection. The lungs aren't the only part of the body that is affected by COVID-19, however. Probably all of our body is affected. But in terms of getting into hospital, ending up needing respiratory support, going to intensive care, and unfortunately dying, the lungs are by far the most important component. So what about 18 months, 2 years ago, almost 2 years ago, in another few weeks actually, is when we first heard about this infection. This was in the Wuhan area of China. And initially, people were watching it, unclear exactly how big it was going to be. Once it left the Wuhan area and cases were found throughout the world, we realized that there was going to be a big issue. And there are lots of estimates about the kind of problems we may get, including some predictions that 1 in 10 of us would be in hospital during the outbreak. Luckily, things haven't been that bad, but they've not been good. Here we can see the impact of COVID-19. This is from about a week ago, and it's looking at the deaths. So the daily deaths you can see on the left. Now, you can probably see what are mostly 3 waves. I would argue in Manchester, which is where I'm based, we've actually had more waves than that. And that gap between the June and October never really happened in Manchester. For reasons still unknown, we had a continuous high level of transmission, which is why we ended up in lockdown longer. But if you look at some of the figures, we've almost got 10 million people, 10 million cases of COVID-19 and total deaths, almost 150,000. So it's been a big, big burden on our societies. And I'm conscious that all of you would have been affected, whether that's catching COVID-19, whether it's your family, whether it's people becoming unwell in your neighborhood or again in your family, whether it's being off school, etc. It's had an impact on us all. But that impact, at least in terms of significant disease, hasn't been even throughout our population. And I'm not using many graphs during this talk, but I'm going to just focus on this because I want to make some points about the fact that science might sound clean and crisp and be removed from other things, but actually it's often entwined with politics. It's often entwined with general life. We realized quite early on in COVID-19 that there was an increased impact on those of non-white heritage. Here you can see Indian, Pakistani, Bangladeshi, African, etc. Because those little dots are to the right, that means people are more likely to develop COVID-19 and unfortunately in this graphic die. Now, what is the reason behind that? Well, there could be genetic elements. There are genetic elements to almost every disease that we have, and that includes infections. But I actually think the top bit there, which is about deprivation score, is also key. So if you live in a deprived area, you don't have much money, you perhaps don't have a job or a poorly paid job, then you are more adversely impacted by COVID-19. And it's a fact of our society, unfortunately, that some of the racial groups listed are more likely to be those in lower deprivation score areas, and in fact have jobs such as carers, which put them more at risk of COVID-19. It has been very tough for the NHS as well. There have been elements and times when we've potentially been at breaking point in terms of not having enough beds to satisfy the demand that we've had. We have had times when we've had to make decisions on rationing resources, lack of intensive care ventilators, almost lack of oxygen in some of the hospitals that we've had. And actually, for those working in the NHS, we've unfortunately lost colleagues who've been directly exposed and caught the infection at work. And we've also lost colleagues who have since left the health system because of the demands of the COVID pandemic. So there's been a big impact on the NHS. And this is actually one of the reasons why we've had to have the social measures in order to protect our health system. But there are also broader repercussions as a result. Because the NHS was suffering, actually a lot of the other diseases, the non-COVID diseases, weren't being treated or investigated as promptly or as effectively as they would do normally. And we're still having to wade through that backlog that you hear about in the news. So what about where it came from? Where did it all start? Well, there's a variety of theories, and I've got a graphic here which just presents some of the more common ones. Now, actually, A and B, I think, are by far more common, but I will touch on C because it gets a lot of airtime. So, SARS coronavirus 2 virus is a bat virus. Bats have a lot of viruses like we do, and they don't normally transmit to humans. Transmitting from an animal to a human, an infection being transmitted, is called a zoonosis. Bats actually are a relatively common source for zoonosis in humans because we're similar in certain molecular ways, and so the virus can jump more easily. The original SARS virus, which is related and also a coronavirus, was also from bats, and the related MERS virus also transmits via bats. So it was in bats, and it's probably been in bats for hundreds or thousands or tens of thousands or longer years. So how did it get into us? Well, if we take A at the top, it could either actually be us being exposed to the bat and catching it directly, or it could be lab workers going out looking for rare coronaviruses, bringing it back to urban centers, and unfortunately there would have been a lab worker infection and released that way. Alternatively, we might have what's called an intermediate host, and a pangolin has been implicated here. So the bat gave it to the pangolin and we got it from the pangolin. At the bottom is the relatively common question of, is it genetically engineered? Was it manufactured in a lab? Well, I'm not sure we'll ever know which of these it is fully, but it isn't obviously genetically engineered. There are often signatures of genetic engineering when things are processed in a lab in that way. And the virus we have doesn't show any of those markers. So I think the purposeful lab creation of this virus is much less likely. So what else do we understand? Well, we've got a good idea, actually quite early on, about what is causing illness, COVID-19, in this virus infection. Excuse me. In the first few days of being infected, what's making you unwell is actually the virus. The headache you may get, the fevers, perhaps a little bit of a mild cough, etc., will be the virus itself. In a subset of individuals, they then develop quite a marked inflammatory response, your body's immune response against the virus. But really it overshoots a little bit. And so we get more inflammation than is optimal to clear the virus itself. And this is the area where most people are in when they end up in hospital. The X-ray I showed you earlier on with the clouding of the lungs is because of the inflammatory response to the virus. And so it's partly us, not just the virus alone. And then a smaller subset of individuals actually end up with what's called a cytokine storm. And this is really where the immune system starts going in different cascades and starts really being uncontrolled, and people get an awful lot of inflammation. And this is what we quite commonly see in those needing to go to intensive care. So what do we do, and what do we generally do when there's a pandemic or something new coming along? Well, we try and get an understanding of the disease, which I've just explained, and then we look at what have we already got on our shelves that might help. In other words, can we repurpose drugs that we've got already? And we tried that with two main classes. There's the antivirals. These are medicines that might directly attack the virus. Now, there were a few possible medicines that weren't licensed, weren't generally available, that had been designed against the other coronaviruses, SARS and MERS. But there are an awful lot of medications that different people around the world suggested had antiviral effectiveness, things like hydroxychloroquine and ivermectin, and even presidents and others were supportive of them. But the actual connection was very tenuous. We've now proven that those other therapies, the hydroxychloroquines, ivermectins of this world, do not work. But like I've just explained, I hope, a lot of the illness that gets people into hospital is actually our immune response. So there was a lot of interest in looking at what we call immune modulating treatments. Can we dampen down or adjust or nudge that immune response in some way or another? There are similar conditions to the cytokine storm that we encounter elsewhere in medicine. We got that data about the importance of inflammation. And anti-cytokines. Cytokines are some of our immune chemicals that really orchestrate our immune response. And knocking out some of those or inhibiting some of those was an obvious route to explore, and actually has proved fruitful with some of the treatments that we use now for people admitted to hospital. But that wasn't the only thing that we did in the early phases, and the only thing that we might have to do more of again in the near future. Social distancing, masks, lockdowns, etc. So social distancing, obviously important. An infection jumps from one person to another. If we put enough barriers between us, it will find it harder to transmit. We're very used to wearing masks now, but if you remember back to the first wave, there was actually quite a lot of controversy around masks, which in retrospect delayed appropriate usage of masks. Now, the reason for that was that we didn't actually know for sure how it was mostly transmitted. Infections can be transmitted airborne, as we know SARS coronavirus 2 is now, and therefore a mask would be useful, or they can be transmitted by touch and contact, and perhaps from our hands to surfaces, to someone else's hands, to their face, etc. And there was an initial thought that masks actually might make it worse because we spend a lot of time fiddling with our masks. And if our hands are contaminated, we're more likely to infect ourselves. That doesn't prove, in the end of the day, to be necessarily true, and masks are vitally important. And obviously, staying at home and lockdown prevents person-to-person contact and transmission. And how important is that? Well, we can do modeling. And here's just an example. And the actual specific numbers aren't too important. What I want to show is the big difference. And I'm not sure if you can see this well, but if we have one person who over 5 days would on average infect 2.5 other people, and they carry on interacting in the same way, in 30 days, over 400 people will be infected from that one individual. Now, if that individual instead has 50% less exposure, halves their exposure to others by wearing masks, social distancing, lockdowns, etc., you can see that it's only 15 people after that month. And if that individual, the first individual, actually cuts their exposure or interactions by 75%, then after 30 days, it's only 2.5 people that are infected. So it shows the power of social distancing, lockdowns, etc. But the big problem with it is it's hard to persist. Even for those of us who are most keen on it, it's hard to keep going week after week, month after month. It's not going to be a long-term solution. Since then, we've developed direct antivirals that target specifically this particular virus. They have been used in hospitals for a while now and soon to be rolled out into the community. And here's an example about how one of them works. For those of you that are doing biology, RNA replicates by having the chain of RNA and then little nucleotides and nucleosides matching it, joining along as another chain, which then splits off. Now, one of these particular antivirals mimics these nucleotides and nucleosides and gets stuck in there instead of the one that would normally go there. And that actually stops that chain progressing. It's what's called a chain terminator. And therefore, the virus can't replicate its RNA and can't carry on. And that's one example of how our antivirals are working. But antivirals and treatment for individuals is not the answer of how we as a population get out of this. It can improve the outcomes for someone who's got COVID-19, either prevent them going into hospital or prevent them needing lots of oxygen or going to intensive care or unfortunately dying. But it doesn't make a big difference to transmission. It doesn't make a big difference to the numbers in our community. The main way out of this is by looking at vaccination and developing vaccines. So what do vaccines do? Well, very simply, vaccines fool our immune system into thinking it's been exposed to the infection. And our immune system develops a protective response. And that's often a combination of the two main arms of our immune system, B cells, which produce antibodies. And these antibodies are important because they stick to the virus and they can prevent the virus sticking into cells and getting into cells, or they can target that virus for destruction. There's also T cells. T cells orchestrate our immune system, but certain types of T cell have direct antiviral action. They can either produce chemicals that have an antiviral activity in our bodies, or they can gobble up cells that have got viral infection, or indeed tell those cells to commit suicide, a process called apoptosis. So even though we talk a lot about antibodies, the T cell response may be very important in COVID-19. And how do we fool the immune system? It's by exposing it to bits of the pathogen or the pathogen. And pathogen is a general word we use for bacteria or viruses or fungi or anything else that's going to cause us disease. Here we're going to be talking about viruses. Now, most and all the vaccines in the UK for COVID look at dead virus or bits of virus. We are not using live but weakened viruses in our vaccines. There are vaccines that do that, like the MMR vaccine that you might have all had, but not in COVID. So it is impossible for the vaccine to give you COVID. Now, what about vaccine candidates? Well, there's a lot of different types. And if I start at the bottom here, we've got those attenuated vaccine candidates. None of those are being used or researched in the UK. If we go clockwise, we can see inactivated vaccine candidates. Now, there's a few of those. That's particularly one called Valneva. It is really taking the whole virus and killing it and using that in the vaccine. In the top left, you can see nucleotide-based vaccine candidates, and the mRNA vaccines have really come to the front here. There were no licensed mRNA vaccines before COVID, and now we've got several. Although the subunit vaccines, taking little bits of it, little bits of protein, little bits of something else, and putting that in a vaccine. And then lastly, like the AstraZeneca Oxford vaccine, we've got the viral vectored, where we've taken an innocuous virus that won't cause us illness or can't replicate in us, and we put bits of the coronavirus in there so that then the immune system is exposed to those bits and it can develop that immune response. And on the right-hand side, I think you can see that most of the vaccines that were being researched are related on proteins, nucleic acids, or viral vectors. Now, we had a head start to preparing potential vaccines. So particularly after the West African Ebola outbreak in 2014 to 2016, a lot of organizations, a lot of universities were planning for disease X. And I remember my mother once phoning me saying, "What's this disease X I've read in the newspaper? Do I need to be worried?" It was a hypothetical disease. The WHO were one of those groups. Actually, the Oxford vaccine group were another group who were already planning how to rapidly respond to an emerging outbreak. And we had some other advantages in terms of developing and designing vaccines. Coronavirus is a coronavirus. So we already largely understood the life cycle. There were a few little bits that needed to be fitted in, like what are the receptors it binds to on cells, etc. But we really understood how the virus works within a cell. And we'd already had two major issues with pandemic potential coronavirus, the SARS and the MERS that I've mentioned. And from those, we had an understanding of the immune response of importance, the immune response that were related to recovering well or developing worsened disease. So in other words, the immune response that we wanted a vaccine to encourage to protect us. And the gene sequence for SARS coronavirus 2 was published very early by Chinese workers, really within the first 2 weeks, which helped globally to mount this effort. And there was a huge effort by many. So a lot of pharmaceutical companies stopped their other development and moved entirely to looking at how to develop SARS coronavirus 2 vaccines and other therapies for COVID. A lot of universities shifted what they did to see what they could do for this pandemic. I lead the Greater Manchester Clinical Research Network, and as Amir mentioned, nationally, the infectious diseases part of the National Institute of Health Research, and we switched almost everything to COVID research. So a lot of people started working on this really full time. How can we check if a vaccine is any good? So we had this head start. People were working to develop these vaccines. Well, we look at two main things when we look at vaccines. We look at safety and we look at effectiveness. Now, safety can be what we call the local and systemic reactorgenicity. This is how you feel for those 2 days after you have a vaccine, whether it's flu vaccine, whether it's COVID vaccine, whether it's something else. You might get local problems, which means around your arm, it might be painful, it might feel a bit swollen, or systemic, which is really your whole body. So it might be the fever or the headache that you can get after you have a vaccine. And we look for other side effects. And in terms of effectiveness, well, the first thing for the first vaccines we had to look at was actually protection against disease and protection against infections. They had to be really big studies in order to find how well it protected. As we've progressed, we get a better understanding of what we call the surrogate of protection, what immune responses we're expecting in people that would correlate with protection against the infection. And so the studies we're doing now have immune response outcomes and are much smaller, or can be much smaller. So a few hundred people rather than 15 to 30,000 people. Now, what about causality if we're talking about side effects, etc.? Just because something happens to someone around the time or after a vaccine doesn't necessarily mean that it's related to a vaccine. I'm vegetarian. If I decided to have a meat burger one day and had a heart attack a week later on, it doesn't necessarily mean my heart attack was related to having a meat burger. So it's important to realize that a lot of the events that happen to people in their lives have multiple causes. And probably it's much more likely for the vast majority of events to have a cause which isn't the vaccine. It's just something else in life. And that includes the blood clots and the other things I'll touch on in a second. In a study, how do we decide what we call the causality? Was it the vaccine that caused this, or was it something else? Well, slightly arbitrarily, we try and work out, is it a definite connection, probable, possible, unlikely, or unrelated? It's not always easy, and it isn't actually always that obvious whether something is probable, possible, definite, etc. Now, just as an aside, you might have had some tablets in your life, or even things like paracetamol, and there's these pieces of paper inside we call the package inserts, and they list an awful lot of side effects. Now, those side effects aren't necessarily causally related to the medicine that you're taking, the paracetamol or something else, because what they put in there is anything that people have reported while the product, while the tablet, the treatment was being investigated. So you often see runny nose, cough, diarrhea, and that's almost certainly in most of those studies or most of those products because people developed a common cold or a cough or diarrhea from food poisoning, etc. So don't always read those and think they are definitely related to causality related to that medication. And here we can get into some confusion sometimes. So how did the UK approach vaccine research? Well, three main things, I think: prioritization, coordination, and support. So there were an awful lot of vaccine candidates out there. There were an awful lot of treatments for COVID out there. And if we'd taken them all on, we wouldn't have been able to get any results because we would have had too few people in each of these different studies. There had to be some prioritization. There was something called the Vaccines Task Force, which decided which were the vaccines that were most promising, but also that we could purchase or develop purchasing deals as a UK in order to get early access for our populations, etc. We had to coordinate our research response. Here's a picture of Greater Manchester, and actually we divided Manchester into 5 sectors, and each of those sectors, all the collaborating NHS organizations, hospitals, etc., got together and could run a vaccine study. So Greater Manchester could run 5 or more studies at the same time, and we wouldn't have been able to do that in the way we could do it and needed to do it without some coordination and collaboration. And there's been a lot of support centrally from government, etc., for our research program. And we've done well. This is one particular study where over a 6-week period, we recruited 15,000 people. It was one of those first studies which informed us about how well it protects against physical disease, COVID, because we didn't have the immune surrogate endpoints that we have now. And overall, the results are actually better than we hoped for effectiveness for all the vaccines that we've rolled out since. Studies generally have shown 95% or higher effectiveness of those vaccines. But there are side effects. Now, side effects may not be detected in the initial studies looking at these because we're talking about a few hundred people or 15,000 people. And if there's a side effect which is 1 in a million, we're very unlikely to see it or to detect it as related. This is where looking at the rollout of the vaccines amongst the population have been really important. And 2 things have stood out. One is blood clots, and the other is myocarditis. Blood clots, particularly in the elderly, related to the viral vectored vaccines like the AstraZeneca, and myocarditis in the younger population, potentially related to the mRNA vaccines. This brings in an issue of how best to communicate risks and benefits. So there's a big difference between what's called relative and absolute risk. If I said that something had a risk of 1 in a million, and then actually something happened and it became 2 in a million, then the relative risk is a doubling, 100% increase. And if I said to someone on the street, this doubles your chance, or this 100% increases your chance of something, then they'll take it very seriously. If I tell them the absolute risk, that it's 1 in a million or 2 in a million, most people put it in a similar ballpark and won't necessarily react differently. So how we phrase it and what risk we're talking about is really important. And then there's the balance between risks and benefits. Nothing in life probably is risk-free entirely. Most of you, I guess, have crossed a road this morning on your way to school or to the shops or wherever else you've been today. And crossing a road has a small but finite risk associated with it. But the benefits perhaps outweigh it. And so that risk and benefit is important to bring into the equation when we're talking about and communicating vaccines and other interventions. It is difficult to communicate, and it's relatively easy to misuse, either consciously or unconsciously, the data. So here's some ways that people have tried to explain those risks related to the vaccines. So at the bottom, we can see that regardless of whether you're 25 or you're 55 years old, you have about a 1 in a million chance of being struck by lightning. Now, if we start going up, you can see there's risks of dying in a road accident, dying due to an accident or injury, or indeed then dying with coronavirus. And you can see how much it affects the elderly more than the young. 800 in a million chance versus 23 in a million chance for the younger population. Now, if we look at serious harm due to vaccine side effects, you can see, particularly in the elderly, 800 compared to 4 in a million. You're much more likely to die of coronavirus than you are to get a complication related to the vaccines. And similarly in the young, but to a lesser degree. Now, another way of looking at it is to use graphical things like this. This is looking at the risk of harms related to the AstraZeneca vaccine related to age, and it's per 100,000 people in a high exposure risk. So during one of the high peaks, the first wave, the second wave, this is what we were seeing. So you can see in the elderly particularly, the risks of having severe COVID, needing to end up in hospital because of severe COVID or ventilated, was so much outweighed the potential risks of the vaccines. Now, when we're not in a wave and we're in a low exposure risk, you can see that the numbers numerically are different, but there's still that age bracket difference. And that's why the AstraZeneca Oxford vaccine is not used in the younger population, but is still potentially used in the elderly population. But you can still mean to give the data correctly, but it can be misused. So here's a tweet that Sky News quite correctly put out there, and it's about long COVID actually, but vaccination as well. Adults who are fully vaccinated are 47% less likely to have long COVID should they contract COVID-19, a new study says. So not only might the vaccines prevent you getting the infection, if you get the infection, maybe you're less likely to get long COVID. And what they're reporting is entirely correct. But a celebrity, I've blacked them out, you can tell it's a celebrity because of the little tick, took this and said, so 53% more likely, that's not impressive. And this, when I found it, had been retweeted and liked, thousands of times. Now, it is not true what they're saying. The 47% less likely doesn't mean conversely 53% more likely. So it is sometimes difficult, and I can understand why people can misinterpret the data. So what should we do? Well, the communication hasn't been good and will never be perfect. I think we need more consistent messages. Unfortunately, when we listen to the news, we quite often get slightly different messages from different so-called experts day after day. So consistent messaging, I think, is important. And it's important to listen and to respond to what people are saying. So here we have a cartoon of some of the points sometimes made, and I'll pick a few out in terms of why they are less keen on taking vaccines. So at the front, did my own research. Absolutely fine to do your own research, but it's really hard in COVID-19. There is so much information there that is scientifically valid and a huge amount of information that is scientifically invalid or unvalid. Even just the scientifically valid stuff is really hard to keep on top of. Taking my chances, that's fine. We should all be able to make our own decisions, but it needs to be an informed decision. It's a complex issue. It absolutely is. I trust my own immune system. Unfortunately, protection against COVID doesn't correlate significantly with how good your immune system is. If you've got a poor immune system, you are more susceptible, but if you've got a good immune system, you're susceptible too. And remember, some of the illness related to it is actually related to your immune system. They developed it too fast. I'll touch on that in a second. Let's wait and see. Well, what are you going to wait for? You know, we have good data, we will get more data, but if you wait, it might be too late. My body, my choice. I agree, but it's about an informed choice. Who stands to gain? Well, if it's an intervention which is evidence-based and proven, we all stand to gain. Population, personally, there will be companies that make a profit, but that's the nature of life. We can all gain from this. Free thinking, absolutely, we should be free thinking. No thanks, that needs to be an informed decision, etc., etc. So let's look at a couple of these in a bit more detail. So quite often people say to me, these vaccines are developed too quickly, something dodgy's gone on. And in retrospect, I think some of the communication from the companies and the scientists who developed the initial vaccines wasn't good when they were saying, isn't this amazing? We've done this so much quicker. So here we've got a vaccine in a year. It normally might take 10 years or so to do what we managed to do in 1 year. And that, understandably, some people listened to and thought, well, have corners been cut? Is there something that people aren't telling me that's going on here? Is it dodgy? I can absolutely say, no, it isn't. The stringency of the studies was exactly the same as we ever have done and what would normally take 10 years. So why has it gone from 10 years to 1 year? Well, I've explained that we've already had a little bit of a head start. We've also avoided many of the pauses and inefficiencies of the usual process. So when a normal study happens, people have to apply for the funding for it. And that can take months or even a couple of years sometimes, but funding was provided really within a week, 2 weeks, 1 month. Needs to go through various committees like ethics committees and regulatory approvals. Those still happen in exactly the same way, but they were brought forward. You wouldn't have to wait 2 months to be reviewed by an ethics committee. It would be reviewed online, possibly the following day. So there were a lot of corners cut in the red tape, but not in how the study itself was run. Also, when vaccines generally are developed, you do the early phase, you wait for the results, you publish them, then you develop the middle phase, you wait for the results, you publish them, and so on, and with delays inherent to that. And here there was a rapid progression from one phase to another as the early data came. And importantly, the manufacturers actually manufactured at risk. So rather than waiting for the initial data, then saying, yes, this is something we're going to invest our money in, we'll make loads of it, they actually started making loads of it up front. Some have lost out in a big way, others have benefited from this. But this meant what takes 10 years could be done in 1 year without changing any of the scientific stringency about how the studies were done. So another thing that people say to me is, I've had COVID, so I don't need a jab. Well, when you've had COVID, it's not full protection. And importantly, the protection you get doesn't persist. And how many of you out there have had or know someone who's had COVID twice now, which is a marker of the fact that it isn't long-term immunity. Now, there's a graphic on the right, which I'm just going to talk over. You don't really need to see so much what the details are, but the top left is the SARS coronavirus 2 virus, the one we're talking about at the moment. The other ones are across the top are SARS and MERS, and at the bottom are the common cold viruses, which are related. And the different lines are different ways of looking at your immune response. And so after natural infection, I hope you can see that actually your immune response to SARS coronavirus 2, to COVID-19, drops off quicker than its related cousins, etc. And the same is true for the vaccines, though actually vaccine protection probably lasts longer, it still wanes over time, which is why we are concentrating so much now on boosters. Another thing people say to me is the vaccines made me unwell. And that can be the painful arm, it can have the temperature, etc. Now, that is true. And unfortunately, a subset of people will get symptoms. They should really, in the majority, only last a day, couple of days, 3 days, etc. Take paracetamol, feel better. A few people will get even higher reactorgenicity, that term I spoke about before. If you think, however, how a vaccine works, it's fooling the immune system into thinking that it's exposed to an infection. So it's not surprising that we develop some side effects as a result, because actually the fever, the painfulness, the redness of the arm maybe, are your immune response. So it's a marker to a degree of us developing a good immune response. And unfortunately, it isn't something that we can necessarily remove completely, but it's a lot milder than developing COVID, etc. itself. So there have been other issues which have caused us problems. The issue of certification. So at the start of the vaccine research program, we didn't expect the vaccines to work so well. We hoped for it, but we didn't expect it. And so there was no real consideration of domestic or travel certification. In other words, travel passports, etc. As the first results came through, however, it was raised as an important issue. But it isn't up to researchers and scientists. This is more of a political question that involves the government. And actually for the travel abroad, in other words, proving that you're vaccinated enough to go to another country, isn't even up to the UK government. It's up to a bilateral agreement between governments. So the receiving government also has to accept and agree that the vaccines that you've had, whether they're study vaccines or deployed vaccines, rolled out vaccines, are suitable for protection. And unfortunately, some people have been disadvantaged because of certification. What about new variants? Well, we fully expect new variants. We always had. All things that reproduce, particularly viruses, have a random mutation rate. So every so often, the wrong nucleotide or nucleoside gets slotted in. Now, people at the start, falsely, I think, said coronaviruses don't mutate very much. It won't be a big problem, but I think they missed the point. All viruses mutate, and this is a new virus adapting to a new host, and therefore the pressure on it to mutate and adapt is much higher than some of the infections that we've had for a long period of time. So we fully expected new variants to develop. Now, some of these mutations, in fact, the majority of mutations are harmful or of no benefit, and therefore no selective advantage of that virus, but occasionally one comes along with an advantage. And these variants, if they spread, become what we call variants of concern. And what makes a variant of concern? Well, it's an adverse impact on either infectivity or transmission. It's more likely to jump from one person to another. The numbers might go up. Or it may be more likely to cause severity, increased severity of illness. Or importantly at the moment, it may be something that allows the virus to escape your immune response. That immune response, which could be related to natural exposure or to vaccines or these things called monoclonal antibodies, or potentially some of the treatments that we might give when people have COVID, though we haven't encountered that as yet. Now, here we get into Omicron, which is the most recent of the variants. Here's a picture of the spike protein. Now, the yellowish bits there are where the new mutations are discovered on this particular spike protein or this particular virus. Now, if you look at the picture on the right, that's looking from the top. That bit in the middle is the bit that sticks on to what's called the ACE2 receptor on your cells and allows the virus to get into your cells. It's also the bit where our immune system, our antibodies particularly, fight against. So antibodies can actually stick to this bit and prevent it sticking to its receptors. But the yellow bits have changed. So the antibodies we developed against what's called the wild type virus may not bind well to what's called the receptor binding domain of the Omicron variant. And so this week and next week, we're actively awaiting data that estimates how much impact this new variant may have on what we call immune escape. Now, how can we tell that? Well, we can't really, we don't want to await the natural experiment. It would take many, many months to get an idea of how much more this particular variant can escape our immune system. So there are things that can be done in a laboratory. And here's an example of what's called a pseudovirus assay. So this isn't the SARS coronavirus 2 virus, it's a dummy virus really, but it has the SARS coronavirus 2 spike protein attached to its surface. And it has something called luciferase within it, but it could be other markers as well. And so what would normally happen is this pseudovirus attaches to a cell, gets into the cell, and luciferase is produced, which makes it light up, or there could be other markers, like I say. So we can develop pseudoviruses with the Omicron spike protein on. We can then expose it to the antibodies from our blood if we're vaccinated or from some of the treatments that we use. And we can see if that virus can enter into cells. If the antibodies work, the virus doesn't enter, and we don't get the luciferase. If the antibodies don't work, then it's not blocking the virus attaching to its receptor, and we get the luciferase. And that's what we're expecting in the next week or two. So what do we need to do for continued success in vaccines? We need to keep going with surveillance. We really need to look out for these variants that develop and react to them. And again, a little bit of politics here about South Africa being the first to report this. This Omicron may not have developed in South Africa, and they're, in their views, being penalized at present for the fact that they discovered it first in terms of travel bans, etc. We need to be able to rapidly develop new vaccines against variants that come up, but rapidly doesn't mean next week. It takes weeks and months to develop a new vaccine. We need to continue having willing participants for the studies to know if our immune responses are improved with the new variant vaccines, etc. We have vaccines registries. The biggest one has over 500,000 people who've expressed an interest, but we need the general public to still participate in our studies. We need to rapidly generate meaningful data, which means well-designed studies, and not keeping the data back, but releasing it quickly. And then we actually need to be able to produce vaccines in large quantities quickly, both within the UK, but also internationally. And you can see I've done an asterisk under rapidly developed new vaccines and manufacturing capability, because actually the mRNA vaccines have potential advantages in being able to be adapted and manufactured in bigger quantities more quickly. So where were we going? Well, we were, until about a week ago, focusing on leaving no one behind. Studies still in children and adolescents to work out the right dose of the right vaccines. We've got good vaccines. Can we improve them even more in this population? Similarly, pregnant women. And what about those with poor immune systems where they don't respond well to a vaccine? Perhaps there's other modalities like actually providing antibodies by an injection for those individuals. And we want long-lasting good immunity. So we were spending a lot of time, and we still will, on booster studies, which combinations of vaccines give you the longer-lasting protection generally, and to cover new variants such as Omicron. Unfortunately, it's not over yet. When I first became the national clinical lead for the COVID vaccine research program about 18 months ago, I thought it'll be 6 months and I can get back to my normal day job, but it's not looking like that quite yet. So I ought to stop there to give us time for questions, and thank you very much for the opportunity of being able to speak to you. Thank you.
Okay, thank you, Andy. That was absolutely fascinating. I enjoyed that hugely. We don't have any questions so far in the Q&A function. I think they've been fascinated by what you've had to say. I have some questions of my own, and maybe my colleague, Dr. Holly, may have some questions of her own as well. As a pathologist, and I can relate to what you said about poor communication, because I do pathology of two kinds. One, diagnosis for the living, but I do postmortems for the coroner. And in the very first few weeks of this, I couldn't really find out what I needed to do to protect myself from getting coronavirus from those patients that were being sent to me for postmortem examinations. So it was bad. It was, we made up our own rules. And in fact, we probably made up the right rules. What about other issues of communication? Do you think that we need to learn something about communication in terms of the next pandemic, which I think you've already alluded is something we have to look forward to?
Yeah, absolutely. I think communication is really important. And scientists and researchers are used to talking to scientists and researchers. And so we don't necessarily perceive some of the difficulties with communicating and communicating correctly. I do think there are many things that perhaps could be better, and I hope will be better. There's nothing wrong with saying we don't know. And right at the beginning of a pandemic, we don't know. I've alluded to the fact that we didn't know whether it was transmitted mostly by touch or by airborne transmission, etc. I think pretending we know when we don't is a very bad thing. I think another thing that occurs to me quite often is the experts that you see on the news or otherwise giving information are experts in their own field, but they're often being asked questions that perhaps beyond their expertise. And I think we have to be careful that the expert opinion out there is the up-to-date expert opinion, and it's consistent. Now, whether we actually need, therefore, to have better trained individuals whose role it is to communicate, I don't know. That would be a political decision. And I think we have to be much more savvy and much more understanding about better ways of communicating, not just the news at 10, but social media, etc., and how to combat some of the adverse social media that's been out there as well. And there has been significant adverse social media out there. So I don't have an answer to that. Some of the audience may be much better at communicating than we will be. But I think one of the things that we'll take from COVID is that this has to be a major focus of interest.
You did something very interesting there about pretending to know when we don't. I think that's something we should leave to professional politicians. So
I won't comment on that.
Okay.
We have a question. We have a question from Stockport Grammar Sixth Form, and they are asking, to what extent has miscommunication affected the trust of the public in the NHS healthcare in general?
Right. Well, that's a very good question, isn't it? And, who knows exactly, having just said we shouldn't pretend we know. I mean, I think there has been a lot of adverse publicity that's gone out there. I think the NHS itself has largely escaped from that because I think people realise the pressures on the NHS and the extraordinary things the NHS has managed to achieve. I think certain branches of science have been impacted, but it's interesting when you look at surveys, and surveys are always problematic because who are you surveying? But if you look at surveys, actually the general trust in scientists and researchers has gone up a little bit over this period. But I think that probably gives a false message. I think there has been an impact. There has been an impact on vaccines. A lot of the people who are against having vaccines are actually against having COVID vaccines, but are still happy having their flu vaccine or their MMR or something else. And I think that's very interesting because it's been associated with COVID. So I think there has been an impact. Exactly how much of it, don't know. Really good question. Wish I could answer it. Wish I could solve it.
Fantastic. I think that was a seriously good question. We have until I think 2 o'clock until we have to stop. So please post your questions into the Q&A. If you don't, you'll have to listen to me asking about the things I want to know, because I have a whole bunch of things that I find interesting. You mentioned that prolonged lockdown in Manchester that went between the first and the second week, and you've already said you don't really know why, but there must be hypotheses. Any ideas that we need to think about? Well,
no, I haven't got a take-home message from this, actually. I thought it was very interesting because I don't believe it was because the Greater Manchester population were not behaving compared to the rest of the population. I think we were. I think there are always going to be some people who didn't follow lockdown or didn't follow regulations, but I don't think it was particularly any different in Greater Manchester than many other parts of the country. I think some of it may be luck. I think we have in Greater Manchester areas a very significant deprivation. And I alluded to the fact that our deprived populations, unfortunately, are more adversely impacted, and that might have had an impact as well. And if you've got a higher rate overall because of your population, then you haven't dropped down as far as anywhere else has. And so there'll be that continuing cycle. So again, regardless of what certain politicians said, I don't think it was because people in Manchester weren't following rules. I think we were. I think we were just being unlucky, actually.
Okay, I'm just going to ask a question, then Dr. Holloway will act as a mouthpiece for Stockport Grammar Sixth Form again in a moment. But this is a question from St Ambrose College, which I think is not far from where I live in Altrincham, and it relates rather closely to something I was about to ask you myself. The question is, how do scientists gather data on rate of transmission? And my question to you would have been, what has happened to R?
Yes, we don't talk about R so much anymore. I did actually have it on one of the slides and I skipped past it. So the R is the reproduction number. So it's the average number of people that another person infects. Now, we don't, I think, talk about R so much anymore because it's so impacted by our activities and our behaviors. It isn't just about the virus. Now, I think if we didn't have lockdown, we didn't have masks, everything was the same, then the R of the different viruses, we could compare to a degree. But because we're doing these interventions to prevent exposure, we can't easily work out R, if that makes sense, because the reason we haven't got transmission is because of the mask rather than because the virus is less transmissible. So it starts getting really complicated. And again, a really good question of how can we kind of determine the infectivity? Well, we can, in the early days, I should say this, we could work out R because of the outbreaks and things like cruise ships, and we could work out how many other people were infected without social distancing. We can't do that now. We can get an idea overall of infectivity in a laboratory, but it's faulty. One way we can work out the transmissibility risk is by looking at the relative rates of the different variants in our different populations that are presenting with infection. And we can work out severity that way. So if we find that 80% of people in the community who are well are infected by one virus, but only 30% are in hospital and it's other viruses, we can conclude actually that probably over time means that 80% virus is less virulent. In other words, there are more people in the community who aren't needing to go to hospital, and in hospital it's a different proportion, but it's a very difficult field. So I'm not sure I answered that very well, unfortunately.
We have a lot of questions here, I think now. It's about sorting some out. So one question is about research on the impact on ethnic minorities and what work has been done about that.
Yeah.
And I suppose another one, which sort of not related, but you could answer perhaps together, is about, do we think that it's realistic that we could end up living with COVID like we do with common flu?
Okay. So the first one, really good question again, and unfortunately, probably not enough research on ethnic minority groups. There's been quite a lot of research on vaccine acceptance amongst different ethnic minority groups, but less so on the impact. So we're still not 100% clear how much might be the increased predisposition might be related to genetic or other factors, and how much might be related to lifestyle and deprivation, etc. We don't know. It's going to be a mixture of both. In terms of, are we going to live with this? It's not going to go away. It will, over a long period of time, mutate to being less virulent and become like a common cold or like the flu, but that could take quite a while. It's a little bit unknown. My own view is we're still going to have problems. We probably are going to be in the situation of having periodic booster vaccines like the flu once a year for at-risk groups, etc. And we're going to have to ride this one, but it's not going away, I'm afraid.
Okay. I'm going to allow this to continue for perhaps beyond 2 o'clock, if you're happy with that, Andy. And
of course.
We'll understand if people have to leave. This seriously interesting question from Wigan and Lee. Because we now have mutation in the spike protein, is this going to affect the accuracy of the lateral flow tests that
wow,
lots of people out there, that's smart, isn't it?
That is
taking twice a week.
There are some amazingly good questions here. The answer is, well, we're waiting for that data as well. So there is something called S dropout or spike dropout, not just actually on lateral flow, but some of the other tests that are done for diagnosis. And we know that certain strains can have this S loss. Now, it doesn't mean that if you go for your PCR test, it isn't accurate, because actually they do several tests on it. So if you go for a PCR and it says you haven't got coronavirus, then the PCR is negative. Lateral flow isn't as accurate anyway as a PCR test. And we're waiting to find out whether there is an impact of this new variant. So very good question, and I can't answer it, but I'm happy to say I don't know the answer.
Okay.
There is another question. There is one question on, I suppose, social media, which fits in with what you were talking about, being informed. But I suppose it's about, is the information you're correct that you're relying on to being informed? And they're asking about what the contribution of social media is to being sort of think you're informed, but in fact you're being misinformed.
Again,
to make a decision.
Yeah, again, excellent questions. And I think the audience will be even more aware of the importance of social media in terms of how they gain their information, etc. When I was young, there wasn't an internet, so let alone social media. And so you got it through traditional channels like newspapers and the news on television and the radio, etc. Different generations get their information from different sources, and that's entirely correct and entirely appropriate. The trouble with social media is that you can almost find anything on there if you wanted to. You can find that Elvis is still alive working in your fish and chip shop or anything like that if you really wanted to. So it's that unregulated nature that is difficult, and also potentially influencers, that one thing can almost become viral because one person has said that they support it. I don't have the answer to this. I think this is something really that would be important to look at and work at over the next few years, is how to try and make sure that the information people get from a whole variety of sources, including social media, is as accurate as it can be to inform people's decision making. And if people are informed correctly and decide not to have a vaccine, absolutely fine. It's about being informed correctly.
Okay. Someone's asked whether the symptoms of Omicron, and of course I might add my own question, how do we pronounce Omicron correctly? But are its symptoms different from those of the variants we've seen so far?
We don't know yet. I think the overall symptoms are going to be the same. It's still the same virus with some minor changes. It's still doing largely the same things in our bodies. Is it more virulent? Is it more likely to cause severe disease? We don't know yet. Now, the initial word from South Africa is no, but actually the data isn't complete enough for me to be happy with that by a long way. So they've looked at the people they know have got Omicron, and they've said, actually, they're less in hospital than we probably would have expected generally, but there's something called case ascertainment here, which can really bias things. So I think actually it's still a very open question, and possibly in the next week or two, we might have an idea of how transmissible and how much more virulent or less virulent it is.
Okay, I think there are just two also related questions, and I think I'm then going to bring it to a halt. There's a question about the long-term effects of coronavirus disease 19 on the individual. After all, we do have viruses that come back and do things to decades in the future, and the long-term effect on us as a population. And the examples that have been used are, will it be like polio or the plague? Polio I can quite understand, plague is perhaps a little different.
Okay, so let me take the second one first, which is what's it going to be like in the future? Naturally, over a period of time, but that period of time could be months, years, or decades, infections that are introduced into a new host will tend to become less virulent. It's not going to go away, which I said before. So I think this will evolve perhaps to being a little bit more like flu. And remember, flu gets people into hospital and unfortunately kills people as well. And then maybe longer than that, it might become even less virulent. Let's wait and see. In terms of long disease, this isn't one of those infections which can linger in you. It doesn't have a long-lasting form in you. Some infections do, but this doesn't. So once you clear the infection, you've cleared it. You can catch it again potentially, but you've cleared it. So there won't be a kind of relapse of your first infection later on. You can catch it again, but that doesn't mean people aren't going to have disease. So one of the issues here is long COVID, and we don't really understand long COVID yet, where people can have lung problems, fatigue problems, concentration problems, problems with their muscles and their joints. There's a lot of active research going on to describe and to try and find out the causes of that at this stage.
Okay, and I'm going to allow one more question because someone has managed to burgle our chat because we've gone past this question in the Q&A. He's called James. I'm going to look out for you in future, James. He wants to know about herd immunity. That is actually one of the things I'm interested in as a pathologist, but his question is, and I'll read it out, how effective is herd immunity with the increase in variants and the increase in effectiveness of the vaccine?
Okay.
I mean,
yeah. Well, herd immunity, yeah, absolutely. Again, a lot of data we don't really know. So herd immunity works for some infections and less well for other infections. Herd immunity is when enough of your population are immune, then the infection has a difficulty transmitting because most of the people it encounters are immune. So it can't kind of jump easily from one person to another and become a big thing. Now, you're entirely right. In terms of variants, it isn't just the impact on the vaccine protection, it's the impact on our own bodies' antibodies that we've developed against natural infection as well, because we've neutralized the virus by developing antibodies within us that bind to the receptor binding domain. If that changes a lot, the antibodies we've got floating around won't work so well. So herd immunity will help to a degree. It isn't the answer. And unfortunately, big variant changes like Omicron probably knock it back a little bit. So I don't think put your money in herd immunity.
Okay. Fantastic. I think that's been a brilliant lecture. I think that's been even better Q&A session because it's answered some of my questions. Whippy, what more do I want? I think that's absolutely fantastic. Thank you very much. And thank you for the participants. And thank you for those really seriously clever questions. I hope all of those who've posed those questions will consider coming to what is probably the best medical school in the country, which is ours. Thank you.
Yay.
Okay, thank you.
Thanks very much.
Okay, thank you. Right, oops, I'm going to stop the Q&A. Oh, that's just people thanking us. That's